And I've actually tuned into quite a few of these, and I found them very educational. So well done. It's a academic, it's a clinical downtime everywhere. So this is a perfect opportunity to catch up on neurology. As Donna said, I trained in Sri Chitra, before that in JIPMER, and I've been in the UK for some time now, and a short stint in the Mayo Clinic as well. As neurologists, we're very lucky to be in a generation when we have seen so many great advances happening in subspecialties. And in autoimmune neurology, I have had the opportunity to be a ringside, largely observer, but made small contributions in the field of NMO. And I'm very happy to share my what I've gathered and an update on how things are live for MOG-AD. I'm aware that this is a very mixed audience of a variety of levels of knowledge about MOG. So I'll try to build it up, and hopefully by the end of the next 45 minutes, you will be up to speed on and how people think about MOG currently. I plan to take you through MOG, the antibody MOG-IgG, MOG-AD, in the context of NMO and MS. I will talk about clinical features and when to suspect, imaging, MOG versus aquaporin for NMOSD, the current approach to treatment and uncertainties, for which there are quite a few, and then lastly, a brief international survey on MOG treatment. So what is MOG? MOG is myelin oligodendrocyte glycoprotein. It's a myelin membrane protein. It's a very small portion of the myelin total proteins. And it's exclusively in the CNS, on the oligodendrocyte and on the myelin sheath. Its function is still not quite certain. It most probably contributes to something for myelin integrity and cell surface interactions. It is, I think, relevant to look at the evolution of MOG-AD, as Dr. Kodari was saying before. Things have MOG-AD has now come to the forefront, but there was a time when it came and then went. So it's perhaps a good idea to sort of look at the whole evolution of MS and demyelinating diseases. If you think Charcot was responsible for defining MS as we know today, and Devick responsible for the definition of NMO, but unfortunately for Devick, in the absence of a clear biomarker, NMO was largely, for the most part of 20th century, considered a severe variant of MS. Until 1999, when Brian Weinschenker formulated a stricter criteria that separated out NMO from MS. Brian was quite lucky in that, Van der Leyen described the antibody a few years later, and that has led to NMO being considered a distinct syndrome. Now, MOG is not a new player. In fact, we know about the MOG-EAE model in MS. In fact, in 1980s, Chris Lennington, Hans Lassmann, they considered MOG-IgG was a marker for MS more than anything else. But as you will see, the antibody was found in other conditions, normal controls, and it lost its charm. Until recently, when Kevin O'Connor's team in Yale described MOG-IgG as a marker not of MS, but of other autoimmune diseases, particularly ADA. And then we realized that, I can't seem to move the slide. Yeah. And then we realized that a proportion of patients with NMO who were negative for AKP4 antibodies had MOG-IgG. So therefore, MOG-AD came under the spectrum of NMOSD, from which we are now trying to segregate a bit more. So it may be of relevance that, how did this confusion happen? How did researchers mistake this antibody against MOG? and thought it was present in MS. Well, the answer lies in the epitopes, the antigen that they use to detect MOG. So if you remember your immunology, this is the antigens have linear epitopes, and they have conformational epitopes. So multiple parts of the three-dimensional structure of the protein, there are multiple epitopes that need to be represented to the antibody for it to bind. Western blots and ELISAs that were used in the 80s were actually used linear MOG as substrate. And sera of healthy persons have a harmless antibodies that binds to this substrate, while pathogenic antibodies only bind to folded MOG. And therefore, these harmless antibodies are detected and thought of as MOG-IgG, and that is how it came into vogue and went out of vogue. But when Kevin did his work in 2007, he took the MOG protein and expressed it in a conformational manner, the folded protein, and in radioimmunoassays, he demonstrated that ADEM patients had a much higher values for the antibody as compared to all the other controls. Kevin's work was then taken upon by people who were using cell-based assays, and that's how the MOG returned. I'm sure Star Wars fans will have a smile at this point. So Kevin's work was then taken upon by others, including Patrick Waters and Angela Vincent in Oxford. And I'm sure you've all seen pictures of cell-based assays. So we are trying to create an ideal environment for the binding of the antibody to its cognate antigen. So MOG is the antigen. We know that it's best for adequate binding, it's best expressed on a cell membrane in its conformational state. So using plasmids and using hex cells, you allow the expression, you create the expression, you express the protein on cell surface, and we use the full length of MOG. That's the full length of MOG here, and that's the short form. We use the full length of MOG expressed on cells, and then you expose the sera to it. And the MOG antibody, pathogenic MOG antibodies, IgG1 subclass. There are four IgG1s, 1 to 4, and MOG is IgG1. So the IgG1 antibody binds to the antigen, the protein on the hex cell, and then we use an anti-human IgG1 against that particular against the bound antibody, and then you have a fluorescent protein. So this is a very precise and specific way of getting to the right antibody. And you can see here the expression or two positive cases. This is the Euroimmune assay that we use in India. You can see that they express the fluorescent protein, fluorescent tag showing up very clearly on the cell surface. This is the live cell assay, where you can see it's more uniformly distributed. Growing live cells is difficult and it's not easily available, so only select centers do it. But for widespread application, the Euroimmune assay based on fixed cells has taken off. So the assay is very sensitive and specific, and that helps us very much in terms of diagnosis and describing varied phenotypes. If the assay was not specific, then we'd be in trouble, because anytime you describe something as a variant of MOG disease, if the certainty or the confidence in the assay would be an issue. But now that the assay we think is quite specific, we have higher confidence in the veracity of the described syndromes. The antibody crosses the blood-brain barrier, the mechanisms of which are still uncertain. At least in AQP4 disease, we think the activated T lymphocytes have a big role, and it accesses the target antigen, that is MOG, on the myelin and oligodendrocytes in the CNS. This is the case described from London, and you can see there's large tube-active lesions in the brain. and long correlations here. This is the control sections, and this is the lesion itself. Using myelin stains, the control section, you can see it's well myelinated, while myelin is significantly lost here. In the axons are in the control section, and here it's lost. Macrophages, not many, but plenty here. And astrocytes are reasonably well preserved. I'm sure there is some loss, but it's reasonably well preserved. This is not what you expect in AQP4 disease, where you would see a significant loss of astrocytes and loss of GFAP staining, but there is preservation of myelin. So this is sort of the pathologic hallmark of MOG. The inflammation is restricted to the CNS, but in CSF, certainly you can find raised proteins. Cells can be increased in up to 70%. So 30% it can be normal. White cell counts can be increased, sometimes neutrophilic, and I have had a few cases where neutrophil count was quite high, raising questions regards conditions like meningitis or Behçet's and things like that. CSF bands are present about 10%. CSF myelin basic protein, which is a myelin degradation product, is elevated as expected, while GFAP, which is an astrocyte protein, is normal. The MOG concentrations are lower in the CSF than in serum, largely because the production is in the outside the blood-brain barrier. So we have this antibody produced in circulation by B cells or plasma cells and causes the first event. So what happens to these antibody titers? If this is a Canadian study of children who had acquired the demyelinating disease. And in this column here, you can see that 67 patients were positive. And if you follow them up for more than a year, half of them became seronegative, but half remained seropositive. 36% became remained as seropositive. And 7%, the titers tended to fluctuate, going above and below the cutoff for positive and negative. In the negative patients, majority of them remained negative, while a small portion became seropositive. And again, one fluctuated. There were borderline cases, depending on what we call the cutoff is, and some became seropositive, and some became negative. How long did it take for these titers to fall and become seronegative? So if you look at this Kaplan-Meier curve, so this is the time from the first sample, and this is the proportion of patients who were seropositive to begin with. So at day 0, they were all positive. And as time goes on, the number of patients who are positive drops. So by about 4 years, about 60% of patients have become negative, but 40% still remain positive. The clinical presentation of MOG and what age does it occur? So this is a UK study. You can see that the age range spans infants up till 80 years. But there are peaks. You can see the peak in young adults and in around 30 years of age. But no age group is exempt. Again, you can look at the phenotype with respect to age. We can see that the commonest phenotype is ADEM, and that is seen mostly in children. This is the young age here. Then we have optic neuritis and transverse myelitis, again peaking in mid-adulthood, followed by optic neuritis on its own, unilateral or bilateral, and then we have TM on its own. So it spans a lot of presentations, and there are some age defined clinical presentations too. In fact, if you draw a graph of the ADAM phenotype versus the opticospinal phenotype, you can see that as age advances, the ADAM phenotype declines and the opticospinal phenotype increases. It is perhaps linked to the maturation and compaction of myelin, but again, it's not clearly known. We and colleagues from Japan, Dr. Fujihara's group, found several patients who had seizures associated with a demyelinating syndrome. And when tested, they all turned out to have MOG. You can see here that there's a cortical extension of these lesions with deep parenchymal extension as well. In some of the Japanese cases, we can see the cortical involvement is largely in a gyriform pattern, just like you would see in post-status or post-seizure patients, only cortical swelling. This is a unilateral cortical swelling, and there are cases where it's bilateral cortical swelling. You can see that there is a bilateral medial frontal swelling here. Bilateral medial frontal swelling in these areas too, with some enhancement. This is a case of ours, a young child who came with, again, a MOG positive, the headache, altered speech, reduced consciousness. One would think it's encephalitis in a focal area of abnormality, okay, and with the diffusion restriction and ADC, corresponding ADC, and no significant enhancement. So it is entirely possible that a variety of focal encephalitis or encephalitic syndromes without any viral markers, a proportion of those could be actually MOG. There are, of course, rarer presentations, optic perineuritis. The optic nerve sheath is involved, and there's disc edema, there is some peripheral vision loss, but the nerve itself is relatively spared. We know about isolated conus involvement, which can happen in MOG, aseptic meningitis, MR negative myelitis, myeloradicolitis, cranial neuropathies, coexistence with NMDR antibodies. A variety of these syndromes have been described. And much of this the confidence in the syndromes relies on the specificity of the tests. Are there criteria for MOG? The Mayo group proposed a rather simple and therefore, at this point, useful criteria that defines it as a cell-based assay positive for MOG, along with any of these core clinical criteria, which is ADEM, optic neuritis, transverse myelitis, brain or brainstem syndrome, or a combination, and excluding alternate diagnosis, which is what we are practically using. Clearly, none of these newer, more recently described entities have been considered yet, but I'm sure the time will come. What does the MRI look in MOG? The first thing I want to say is that in majority of cases, and we have about more than 100 cases now in our own center, majority of cases that present with optic neuritis or transverse myelitis, the brain scans are probably going to be normal. In fact, one of my PhD students have spent the last few years, she just passed a viva. One of the projects was to look at serial images in MOG. And in patients with pure optic neuritis and TM, the lesions were minimal. There are some small lesions, of course, but there's no dramatic lesions are only seen when there are actually brain presentations, whether it's diencephalic or cerebral or brainstem and so on, or ADEM-like presentations. Before we go into the images per se, it's good to revise, because many of you may not be seeing lots of MS, to think about the typical MRI in MS. So here you can see the periventricular lesions perpendicular to the fourth ventricle. We can see the Dawson's fingers. This is the S-shaped lesions or U-fiber demyelination, subcortical demyelination. You can see cortical lesions in the small box here. You can see the central vein sign. We know that lesions in MS are formed around blood vessels, around veins, and there's a central vein sign which is seen in around MS plaques, and less commonly in AQP4 NMOSD and in MOG. And obviously the short peripheral lesions in the spinal cord. Let's look at some of these. Um, let's look at some MOG versus MS to get our eye in. So this is an MS lesion, okay, periventricular lesions, Dawson's fingers like, and this is a MOG lesion. It's not, I mean, there are differences as you can see. You can see the MOG lesion, periventricular lesions versus MS lesions. Cord lesions, short MS lesions, where long myelitis in MOG. It is useful to, in general, when thinking about MS mimics, when you see a scan and if you think it is, is it MS or something else, this mnemonic by the Magnum's group can be helpful. It's called iMimic, imaging mimics of MS. So M stands for meningeal or a complete ring enhancement, which think about other conditions. I mean, none of this is an absolute, but still think of other possibilities. Indistinct borders, fluffy, cloud-like appearances, microbleeds, infarcts, cavities, U-fiber sparing, and symmetrical lesion. Think of leukodystrophies. So let's look at some MRIs in MOG. So this is from literature. So this is from Sven Yarius' group in Germany, and this is Ho-Jin Kim's group in Korea. So diencephalic lesions, capsular lesions, fluffy lesions. And I'm going to run through this very quickly. Some lesions look, a bit fluffy, but still in the callosal region. So cortical lesions, fluffy lesions here, some brainstem lesions. I don't know if you can spot the enlarged optic nerve there. You can see subtle fluffy lesions. I mean, many a time you can say this looks like MS, and I would agree. On its own, a single lesion will not be able to tell you, but it's the overall picture that may guide you, and often it is very difficult. Cerebellar peduncle lesions, fluffy large lesions. This is a patient of mine who had the previous lady itself, this particular scan, and on follow-up she had a new enhancing lesions. Further lesions, some temporal lobe changes, anterior temporal lobe changes. Okay. May look non-specific. It could be MS, could be MOG. Fluffy lesions, tumefactive lesions, diencephalic, upper midbrain lesions, middle cerebellar peduncle lesions. Temporal lobe, this patient actually, one of my patients who had seizures, and he had a biopsy as well, but he had temporal lobe changes. Pontine changes, okay. Cord changes, long cord lesions, subtle pontine changes, long cord lesions again, several here as well. Okay. Lower cord involving the conus. So what happens to these MRI lesions with time? This is some work from Mayo again. So these are the acute changes. You can see several fluffy lesions as we saw before in the acute stage. And after treatment, on follow-up, majority of these have disappeared. And this is our experience too. But not always. This is something we published a while ago. And this is a man who happened to have had a scan prior to his first index event. This is actually a man in his, I think, his 40s or 50s. He developed what thought to be stroke-like or vasculitic-like episodes, multiple brain lesions, and had recurrent episodes of these. You can see this large occipital lesion, which left him with the hemianopia. And with time, you can see the ventricle enlarging and the cortex atrophying. And this is after a few years. You can see actually it's 1 year, the cortex is quite atrophic. So it does leave behind sequelae. It probably depends on the host factors and the degree of inflammation involved. The same patient, actually, he was left behind with a mild hemiparesis, seizures, and aphasia from this lesion up here in the motor area. You can see the Wallerian degeneration spreading down from the affected area, and you can see the cortical atrophy as well. So I must hasten to say that not all brain lesions disappear, and some of them can leave behind significant radiological sequelae and clinical, which I'll come to in a bit. So Do patients recover from attacks? They do. This is again from the UK study, and this is the proportion of patients, and this is the index event they presented with. So if you look, the darkest red is poor, the lighter red is moderate, gray is good, and full recovery is white. So optic neuritis, good recovery, but a small proportion is left behind. Bilateral, long myelitis, a small proportion severely affected, and so on. ADEM, good recovery in majority. Age also seems to play a role. The younger you are, the better chance of recovery. Again, just probably makes a biological sense to us. But the point is that while a good proportion of patients do recover, perhaps much more than AKP for NMOSD, a small proportion are left behind with deficits. So that comes to the questions, and you probably know the answer already. Is MOGAD monophasing or relapsing? Well, it's both. If you look at the UK study, so this is the percentage of patients who are relapse-free. This is a cohort of patients who had their first event and then followed up for some time. In reality, what happened was the lab was, all the patients were tested in the lab, samples being sent across UK to a central lab who were positive. We wrote, sent questionnaires out to their treating doctors asking about the clinical outcomes and what has happened to these patients on follow-up. And then we identified patients who have had only incident, only one episode, and they were followed up. And the incident cohort of patients, the relapse risk was that by 4 years, 50% of patients had a relapse, but 50% did not relapse. So if they do relapse, then what predicts the relapse? What markers are there that predicts relapse? The persistence of MOG antibody seem to increase the risk of relapse, which again makes biological sense, but it's not always so. And that's when it becomes a bit more tricky. If you think about AKP4-NMO, the antibody is present. We think it never really goes away, and low levels are sufficient to cause relapse. While in MOG, the antibody may disappear. But as we saw, some patients who are seronegative or borderline negative can turn positive. Some negative patients can turn seropositive. And even if seronegative, a small proportion can relapse. So the cutoff, it becomes important again. If what is the cutoff you're using for seropositivity? If you lower the cutoff, you lose the specificity and sensitivity. So these are issues that labs have to tackle. You alter the sensitivity and specificity. But seropositivity seems to predict relapses. Going back to the Canadian study, they have classified their patients into those who were positive originally and then became negative, and then those who were persistently positive. Proportion of patients became seronegative and some remained positive. And what happened to these patients in terms of relapses? So if you see those who were positive or remain positive tended to relapse earlier, and you can see 60% of patients relapsed by about 4 years. While in those who became seronegative, about 90% remained relapse-free. In a US study of fewer patients, they've divided, this is the Mayo Clinic again, so they divided into 3 groups. Those who were persistently MOG positive, they tended to relapse, and all patients relapsed by 100 months from onset. Those who were transiently positive, that means the antibody was present initially and then it disappeared, they did not relapse, and this is largely children we're talking about. And there was a group who was MOG and AKP4 negative, and these patients, some of them may not relapse. They probably have another antibody. We know of relapsing MDEMs or some of them may have other conditions or antibodies yet to be discovered. But in general, it is seen that the MOG positive patients have a higher risk of relapse. In adults, the same thing is seen. If you're persistent in MOG antibody, patients tend to relapse, not all, but some. And those with transient seropositivity, a small proportion did relapse. So we can see that MOG antibody is helpful in predicting relapses to some degree. I think we have now enough information to compare aquaporin versus MOG versus MS. There are lots of similarities, as you can see. Now, if you're a neurologist, you're a lumper or a splitter. You split into different things or you clump it all together. So I think, in my view, I think MS, and I'm sure many of you agree, MS is a fruit bowl with lots of fruits. And with time, I'm sure there are many more fruits to evolve out of this. And I'm sure there will be a large fruit, the prototypic MS that we all know will form a chunk of it. But there are many more syndromes yet to evolve out of the MS fruit basket. If you look at these three conditions side by side, AKP4, MOG, and relapsing MS, the prevalence of AKP4 NMOSD is about 1 to 4 per 100,000. MS, 10 times that. MOG, perhaps more in this ballpark. We don't have exact figures yet, but I'm sure it's pretty similar or slightly higher than AKP4 NMOSD. Sex ratio, MOG, it's quite, male to female is quite similar. Coexisting antibodies, not uncommon in MOG. Long lesions common. Area postroma lesions are fewer. Brain lesions, as we saw, can be seen if the presentations are cerebral. CSF bands are fewer. Syndromes we talked about, more of ADEM and optic neuritis, and cerebellar lesions, which are fairly uncommon actually in NMO, in AKP4 NMO. Cerebellum is not really that commonly involved. Cerebellar connections can be involved, but cerebellum itself are less commonly involved. But ataxia is, as you probably all know, ataxia you probably would have seen very rarely only in AKP4 NMOSD. Chances of relapses, it's almost close to 100%. And by definition, relapsing MS has relapses. And MOG, as we saw, it can be up to 50% or more as time goes on. Recovery or disability from attacks, you lose function early and a poorer recovery. While in MOG, good recovery is common, but some patients do actually have significant deficits. And I have many patients who have left behind with bilateral blindness, but otherwise well. And of course, relapsing MS, we know. So how do we treat patients with MOG? There are several aspects of treatment, of course. We'll focus on the first two. In my practice, every new presentation of demyelination, I think this is most likely MS, but could this be MOG or could this be AKP4 disease? And I worry about that, and I do not want to undertreat them, particularly bearing in mind the risk of disability. So I give them high-dose steroids, intravenous if possible, particularly if the disability is high, or oral steroids if it's a mild optic neuritis. And in the right context, if the scans are typical for MS, then that's fine. But if it's atypical and the story is atypical, then after I would do a very gradual steroid taper. And someone who's significantly affected, I go for very early plex. Take an example, somebody comes with a long myelitis, he's paralyzed. I would probably plan plex on day 2 after giving a steroid, because I know the chance of recovery is going to be low just with steroids. But someone with very mild optic neuritis and had already a couple of days of steroids and they're doing very well, then I'll probably continue only oral steroids. In patients whom I'm suspicious of a non-MS diagnosis, I would wait for the antibody results to come back. If it's negative and it's probably idiopathic or MS, I taper and stop. If it is positive, I'll give a very long taper. In fact, there's some data that supports that a prolonged taper of more than 3 months steroids may reduce the risk of relapse. And this again comes from the UK data. Again, Kaplan-Meier curves. the percentage of patients who are relapse-free, and the time in months. And you can see that those who were treated had lower chance of relapse, but those who were not treated with steroids relapsed quicker. So how do we prevent relapses? We're trying to apply limited knowledge to tailor treatment. When you compare to AQP4 NMOSD, we think the inflammation is severe, which in AQP4 it's severe. The antibody persists in AQP4 NMOSD. Even at low levels, it can cause relapses, and spontaneous remissions are quite rare. And overall, there's a higher risk of severe relapse. So we all treat almost everyone with a long-term immunotherapy. For MOG, we know that the inflammation is less and less severe. The antibody can disappear, and spontaneous remission is common, particularly in children. And therefore, in overall, the lower risk of a severe relapse. The persistence of the antibody indicates a higher risk of relapse, while its disappearance may be a positive sign. So one can try to be a bit more selective in deciding who to treat long-term. Again, we're trying to tailor treatment. We're trying to avoid unnecessary treatment. And there are always going to be, difficult situations. Now, there aren't many algorithms, and you probably have all the information that you need to have a discussion about treatment. But if you'd like to have an algorithm of treatment, I would recommend what we do in the UK. This looks complex, but it is not. So if you can focus with me on a patient who has come with a typical symptoms of bilateral optic neuritis, shall we say, and they're positive for the antibody. Okay, so you call it MOGAD. As we discussed, we start them on steroids, and we usually give about 6 months of oral steroids. Now, if you have brittle diabetes, children are not tolerating steroids, then you could try alternative immunosuppression, bearing in mind that they take time to kick in. And most of the relapses seem to happen in the initial months. So at 6 months, we retest the antibody. Now, if the antibody has disappeared, then it's great. We think that relapses are probably not impossible, but less likely. So we taper off the steroids. But if the antibody is positive, then we have to think there is still a good chance that this patient may not, this antibody may disappear and the patient may not have a relapse. But on the other hand, if the onset attack was quite severe, or they've already had a relapse by 6 months, and if they're tolerating the steroids very well, then it might be reasonable to continue the treatment. Take, for example, somebody who's come with a, first event was bilateral optic neuritis, and they are now blind, or they got partially preserved vision in one eye. Naturally, everyone's going to be quite anxious about further events. So it's quite reasonable to continue steroids for a longer period. So we continue steroids, let's say, and then we retest in about 12 months' time. The antibody has disappeared. Yes, taper it off over a period of 3 months or so. And if it is positive, then we have to think. If they've already had a relapse, another relapse in the 9 months after the last preceding 9 months, that is outside of the initial acute phase, then the illness has declared itself as a relapsing disease. And then let's continue treatment. But if it is not, there are no relapses, if the antibody is positive, but there's a good chance this might remain monophasic, then we taper off steroids. Almost always there's a discussion. Some patients prefer to be on treatment. They do not want to take a chance. Some patients, young women wanting to conceive. So various other factors come into play as well. That's a general rule that has helped us so far. Now, if we are going to treat patients, what drug are we going to use? Well, we have a lot of choice. We could use the classic NMOSD drugs. We could think about the newer drugs, eculizumab, satralizumab, and inebilizumab, which have all found to be positive in NMOSD. We can think about MS drugs. I have highlighted some of these drugs which have been shown to increase the risk of relapse in AKP4 NMOSD. But do these apply for MOGAD? We don't know yet. So I would be not in a rush to discredit these drugs in MOGAD. And if any of you have experiences in using accidentally or otherwise MS drugs in MOG, you must publish it. Then only we will know. I mean, these are established and reasonably safe drugs. And if they have a role in MOGAD, we should not miss out. We should not necessarily apply everything that applies to AKP4 NMOSD to MOGAD. So some fresh thinking has to be done. These drugs like cladribine, teriflunomide, etc., they have immunosuppressive effects and they can be useful as immunosuppressants. And ocrelizumab is rituximab essentially. So there is a role for that. But in practice, what are people doing? Emily, my fellow, looked at all the publications in the recent past. And from extractable data, from articles where you could extract data, we got these 4 main studies: Ramanathan, Jarius, Hakohen, and Zhou. And the patients that were on treatment. So these are the medications: corticosteroids, mycophenolate, azathioprine, IVIG, and rituximab. This is the duration of treatment in months, the total number of patients, and how many are relapse-free on follow-up. So steroids alone, 57%, on a last follow-up 10 months. Mycophenolate, 69%, azathioprine, 81%, IVIG is 65%, and rituximab, 51%. Romain Marunier and colleagues in France looked at the efficacy of the immunosuppressants, immunosuppression versus no treatment, and they've demonstrated that being on immunosuppressants is doing something. There's clearly a benefit on being on these medications as opposed to not being on any treatments. And in a further analysis, they look at the 3 main drugs, azathioprine, mycophenolate, rituximab, and they found that the relapse rates drop from 1.05 pre-treatment to 0.43, 1.2 to 0.23, and 1.08 to 0.43. What about the newer NMO drugs? Well, there are many drugs. We can think about inebilizumab, anti-CD19 drug, which depletes B cells. We can think about satralizumab, anti-IL-6 receptor, which certainly works for AKP4 NMOSD. We can think of complement blockers, which would be interesting to explore, but complement's role in MOG may not be as much as in AKP4 NMOSD. Clearly, none of these 3 drugs will be easily available to try in MOG. But we are trying to look at patients included in the trials for these drugs who seem to have had MOG and look at their benefit. As I showed earlier, rituximab did not particularly do well for MOG. And this was our original impression, and it was surprising. And some of you may know that one of my very first papers was in NMO was on rituximab in AKP4 NMOSD by Brian Weinshenker and Bruce Cree. And this probably helped the launch of rituximab as the most chosen drug, go-to drug for AKP4 NMOSD worldwide. So I was hoping to replicate this work in MOG, and we asked colleagues from across the country, across the globe, and we got about 120 patients with MOG treated with rituximab, mix of adults and children. But surprisingly, the relapse freedom at 1 year was only 55%, and 2 years was 33%. And relapses occurred despite B cell depletion. We're not quite sure why. Rituximab seems less effective in this particular study. Maybe it is it's a very selected population. Maybe there is other mechanisms at play. Maybe there are T cells more involved. We don't know yet. The last thing I want to talk about is MOG in a survey that we did across the world and asking people how they felt about treating MOG. And maybe you can now think about your practice as I show these results. We asked the question, how many give prolonged steroids more than 3 months after a recent attack? So you might want to think what you would do. Well, you can see that 40% said always, some said usually, some sometimes, rarely, and never. What is the duration of steroid treatment after the first attack? What would you do? Think with me. Again, opinions differ. 3 months, 6 months, 9 months, 18 months, and some test antibodies. How many start steroid sparing treatment after first attack? No, always, no, usually, sometimes, rarely, never. And these are all people who deal with MOG. After 2 attacks, how many will start treatment? 60% always, some usually, sometimes, rarely, never. And there are reasons, I'm sure there are good reasons why people don't start. And how many use serial MOG titers? The first choice of maintenance therapy in a male patient, the majority here choose azathioprine or mycophenolate. Second line, after if the first drug is ineffective or has a relapse on it, then where do they go? They go to rituximab or mycophenolate. And third line, well, we'll try other medications including IVIG, tocilizumab, and so on. When do you stop treatment? Some people say they don't stop. Relapse for 1 year, for 2 years, 5 years, when antibody becomes negative. People are not quite sure. And I think most of us are in the same boat. We don't really know. There's an evolving disease, but quite rapidly so. And then we also asked which MS drugs will be of benefit. And unsurprisingly, ocrelizumab came on top, but the other drugs have also been thought about, but clearly nobody is using it on purpose yet. So experiences will be valuable. And the last question was, how confident are you that you could maintain remission for 3 years? So if you think about your own patients, in somebody with AQP4 NMOSD disease, how confident are you that you could maintain remission for 3 years with the drugs you have? So 7 was the answer for AQP4 on a score of 0 to 10. 10 being I'm absolutely confident and 0 being I'm not confident at all. 7 was the answer for AQP4 NMOSD, and for MOG it was 7.4. People are optimistic. People think that they can control relapsing MOG well, which is a good thing. So I think we're at the end now. To summarize, MOGAD is a new disease with many similarities to AQP4 NMOSD. Testing for MOG-IgG1 with CBA is specific and sensitive. Suspect MOGAD in ADEM and variants, situations where you suspect NMOSD. When scans look demyelinating, but it's not quite like MS. Atypical conditions like you think of autoimmune encephalitis when or non-limbic lesions or NMDAR plus. Unexplained predominantly CNS white matter disease, particularly if they're steroid responsive. It's important to say if scans and clinical features are typical for MS, then don't test. If it turns out as borderline positive, it'll confound the picture. So if it clearly looks like MS, then perhaps we should not test. Despite all the MRIs I showed you and the clinical features I told you, sometimes it's really difficult to clinically or radiologically differentiate AQP4 NMOSD or MOGAD from MS or other demyelination at onset. So the only reliable test we have at present is the cell-based assay. So it's equally important that we treat all the index events quite well. While recovery is good, residual damage does occur in MOG. While monophasic disease is common, particularly in children and in ADEM, a significant proportion of MOGAD can relapse. Persistent antibodies predict relapse, though there are still some uncertain areas. The commonly used drugs for AQP4 NMOSD are effective, but variably. And I think we should not be in a rush to discredit MS drugs. And in every case, discuss the pros and cons of treatment, the uncertainties, and some decisions are not going to be easy at all. Take, for example, somebody has a very mild relapsing optic neuritis and they've recovered completely and their OCTs are fine. There is no loss of retinal nerve fiber. And are we going to subject this patient for the next 5 years of mycophenolate? Or if they are educated, they can easily access healthcare, they are very smart, at the drop of a hat, they will come and call you up and come to clinic, and you can give them steroids again. Maybe they can be observed. So there are uncertainties involved. Our knowledge has rapidly increased, but still there's a lot to be known. I want to thank all my collaborators, the teams at Walton Center and Oxford, and worldwide. And thank you all for listening. I can take questions. Hello?
Hi.
I can't hear.
Can you stop?
Am I audible now?
Yes, you are.
Yeah. So let me begin the questions. There are quite a lot. We've had a huge audience. So the first one is, yeah, okay.
Dr. Anu, can you stop sharing the screen? So.
Oh yes, sorry. Yes. Stop sharing.
I've done that.
Okay.
Okay, so the first question is, how long MOG should be treated with steroids? You, I think, answered it. And steroid sparing agents after the first episode. Yeah, you answered that essentially. There is an interesting question which I think relates more with aquaporin for patients, but probably this guy has found some. If a patient with SLE, Sjogren's and rheumatoid has MOG positivity, what should be the first line treatment? Cyclophosphamide, rituximab?
Okay, so it depends on the severity of the, depends on the severity, I guess. If you got a fulminant lupus or other rheumatological condition along with MOG, maybe to gain control better, maybe cyclophosphamide is probably where you would go. But if it is a reasonable moderate illness and you're thinking of long-term safety as well, rituximab is an option. So in situations like this, I often see what is accessible, who's going to look after the patient, and either of those choices are fine. But to gain quick control, I use cyclophosphamide because it will work both on B cells, T cells. It's got a global effect, so it may help gain control better. But preferably for in a less acute setting, you would want to go with rituximab. And we have patients with lupus on rituximab and MOG doing reasonably well. Sorry, this is more aquaporin and MOSS doing this. So MOG, well, first of all, the coexistence of MOG and other illnesses are less common. So we have not really encountered many patients with MOG and other diseases, but I suspect the same rules apply there.
Absolutely. So the next question is, after an acute episode, how long does MOG antibody persist in serum, and how long? You answered that? Yep.
So it can persist. It can disappear by, we saw the graphs, didn't we? So by year, I think 50% it may go down.
Absolutely. A patient with optic neuritis who satisfies McDonald's criteria for MS.
I just had a question. Do you target the antibody level? Because in many of the antibody disorders, we don't bother about that. You go by the clinical response, whether it's positive or not, or the titer. Do you pay attention to the titer, or whether it is getting negative to decide when to taper?
Short answer is no, because it becomes one, it's difficult. Two, for an individual patient, as a generalization is difficult. Though titers may fluctuate, we are too early in MOG to say with confidence. For select patients in AKP4 disease, you can see there is a rise and fall, and which may help, but overall it is not that helpful.
Okay. So here is a question. A patient with optic neuritis who satisfies McDonald's criteria for MS turns out to have MOG positivity. How to manage? Should we ignore MOG and treat as MS?
Okay. So, I mean, one could argue about what the test itself. If it is done in an excellent lab and it's been tested again and it is positive, or in a different lab, and we often do that. Sometimes a test comes back as in a patient whom we do not expect, then I often send samples off to a different lab. I've sent samples to the US, to Japan, and if they're positive there also, then then the case for MOG becomes stronger. But sometimes you are just stuck. You have to decide on one, and I would choose a drug which will work for both. And in this situation, I would probably go for an MS drug that will work for NMO or vice versa. So rituximab or ocrelizumab, given a choice, would be the way to go. Of course, I'm not too worried about introducing azathioprine or for mycophenolate in MS as well. So because we know that they do work, though perhaps not as well as the other drugs, but they do work as well.
Absolutely. So here is another question. Isolated unilateral optic neuritis. NMO, the neurologist says always negative, and MRI is also negative. So how should we go ahead? Which means he's saying, what about isolated optic neuritis?
So you have somebody who comes with optic neuritis, and scans are normal and antibodies are negative. So in which case, I think it depends on the deficit. If they've recovered completely, let it be. I won't start any treatment. If there is ongoing, if in acute phase, when you see the patient, there is still visual acuity, still low color, and there is scope for improvement, then I would continue steroids for a longer period, because this is not typical MS. And I want to give the patient the benefit of having a prolonged immunosuppression. So we can try to salvage brain tissue or optic nerve tissue back. But I wouldn't consider long-term immunosuppression for these patients, because there is no evidence for that. Unless maybe in 6 months' time, if they have a relapse, then I would restart. Because if you would end up treating a lot of patients unnecessarily, monophasic patients unnecessarily, if you start every patient on long-term treatment.
Absolutely. Now, there is a strange question. Few patients with hereditary spastic paraparesis have acute symptoms of myelitis, and MRI is normal. Should we test MOG? Now, I don't know what this neurologist means. Probably
so if it is known HSP, if somebody has known HSP and is definite, we have done the gene test, then I'm not quite sure. It's interesting, but if it is a clinical suspicion of HSP, then recently there have been patients who had MRI or whose scans were apparently normal. Though they had clinical myelitis, the scans did not show any lesions, and but MOG antibody was positive. And this is, came from the Mayo group, so it's certainly interesting. So in the right clinical context, if the diagnosis of HSP is not certain, then it's probably worth testing. But if it's a definite genetic test positive HSP, I'm not quite sure if MOG antibody has a role, unless you're thinking of two illnesses coexisting.
Two illnesses, absolutely. Now another, it's about CSF. If MOG antibodies in serum are negative and CSF is positive, should we redo the serum tests as they are not done intrathecally? So
the general dictum for all antibodies that are produced peripherally is to rely more on serum. One exception might be NMDR antibodies, where CSF seems to be equally good. I don't have strong feelings on this, but it is unusual to find only CSF positive in MOG. In fact, the Mayo criteria says that if serum is negative, a CSF positivity will be also taken as valid for calling it MOG disease. So yes, it is worth testing, and if a CSF is positive at the right titers in the right labs with the right assay, then I think I would give it credence.
Okay, you second time said right lab, right methodology. So commonly in India, we are using the Urimmune cell-based assay, HEK23. Is that the good one?
That is, I guess, as good as you can get without having a live cell-based assay. Yes, short answer is yes. Okay. Of course, I'm sure people are very good in reading these tests, and experience ultimately is visual, right? You're looking at a slide and calling it, is it bright green, or is it a dark green, or is it not green? If you don't wear your glasses, if the glasses are smudged out, if you're going to rate it 3+ versus 2+ or 1+, you can get it, you may get it wrong. So experienced labs probably can offer consistently good results.
Okay. Dr. Biswakumar asks you about your left temporal lesion. What did the biopsy show? Was there any evidence of HAC, he says? Herpes simplex like thing.
No, there wasn't. There wasn't. Good question. So no, but there wasn't. We got the
There
histology
wasn't.
reviewed. There wasn't anything to indicate that. And the patient made a excellent recovery.
Excellent.
He had some residual seizures though, but now I think he's still on Keppra, but he's doing well.
Prashant asks whether in a child with single brief seizure MRI cortical based lesion, post-ictal changes, MOG is positive. I suppose the changes on MRI, if the MOG is positive, may not be called post-ictal, correct? We should sort of.
Yeah. So this is the question, isn't it? So which came first? Did the MOG antibody cause the lesion and therefore the seizure occurred, or did the seizure cause the gyral changes? From what we know, and from various reports, it is probably the lesion that's responsible, the MOG that's responsible for the lesion. So I would think it's MOG that's responsible for it.
How often do we have to do MOG to predict relapse? I think you've answered the question, 3, 6, and 12 months, I suppose, correct? From the flow chart.
So UK practice, yes, yeah, that's right. So I mean, costs are an issue, isn't it? So 6 months, 12 months are reasonable.
Professor Singhal asks a question that a colleague of his had a patient presented with raised ICP who turned out to be MOG positive, and MRI showed cortical inflammatory lesions. So raised ICP with the cortical lesions is what professor wants to know about.
So I suppose the question is, why is the ICP raised? You know, if there are cortical lesions and MOG is positive, then I'm more inclined to think that's related to MOG. Why is the ICP raised? Is the proteins elevated? Don't we have raised ICP in other forms of encephalitis? Could that be explained? But I personally haven't come across a situation where the ICP was significantly raised because of MOG encephalitis. But you know, this inflammation can be quite severe. You can have lots of white blood cells in the CSF. Protein can be elevated, so it doesn't put me off a diagnosis.
Absolutely. Okay. Another question, but I think you've answered it. How frequently you check the MOG levels? You answered. How about from Dr. Sunita? How about double antibody positive? I suppose the answer is negative. No?
I mean, it's exceptional. It's very rare to have double antibody positive, I think, and that generally holds worldwide. There have been cases who were borderline positive for MOG or Kapur, but by and large, they seem to be mutually exclusive.
Professor Singhal compliments you for an excellent talk anyway.
Thank you very much. I mean, it won't be surprising, isn't it? So at some point, if you think autoimmune illnesses coexist, nothing prevents an AQP4 and a MOG happening together, and MOG with MS happening together. But so far, we have not come across it, or it's never got published, because reviewers are going to say that how can that happen? So,
Okay.
but unless you have histology, it's difficult to prove one or the other.
Absolutely. Dr. Sunita asks, can we consider NMOSD seronegative as includes MOG positive, which means she wants to say are they still under a domain of NMOSD, or should we? That's a very moot question, isn't it? Or
yeah, I mean, the move. There are different camps on this. I mean, people believe that NMOSD would encompass all these things, but I think we are more and more moving away to a classification based on antibodies, like NMDR antibodies, like LGI1 antibodies, syndromes. So it's most likely that MOGAD will have its own status apart from NMOSD in the next classification.
Absolutely. Dr. Meshram, who is our president of IAN, he asks, does MOG has regional predilection? In a series from Sri Lanka, optic neuritis plus transverse was the 70% group.
Yes. So MOG seems to be universally present. It wouldn't be surprising if infectious triggers, as we know, ADEM ADEM is certainly perhaps more common in areas where there's more infection. So it won't be surprised if MOG occurred more in areas where there is a younger population and there is perhaps more of common and viral infections. So that doesn't necessarily surprise us, but is there a big regional variation? I'm not so sure. At least I have not seen any data that supports that.
Okay.
But overall, if you think proportions, MS is probably much likely, less likely in Asia compared to the West. So proportions will obviously reflect that.
Different. Another question for Dr. Dhonde. Optic disc edema with hemorrhages, a finding of MOG encephalitis. How, as a finding of MOG encephalitis, is it something known?
Have I seen that? Probably rare. Most of are typical optic neuritis with disc swelling. Hemorrhages is probably an extreme state. I can't say for sure, but it's possible. I've not seen a case myself with that degree of hemorrhages. But as you know, MOG optic neuritis is thought to be more anterior, so it's not surprising if you saw that, depending on the degree of inflammation.
So a very important question: do steroids drop the level of MOG itself? So that you given steroids for long term, would it just reduce it?
So would steroids lower the level of the antibody?
Absolutely.
Yeah. So what do steroids do? They act on the lymphocytes and neutrophils and reduce their activity. So that includes B cells as well. So yes, they can lower the levels.
Okay. So then in that case, on one side, we say if the levels go down, we stop immunosuppression. On the other side, our steroids itself have done that job. So how do we go about it? You understand? Because the steroids did the thing. So, and then you stop and the patient may just relapse. That
is true. So we know that patients who did not have any treatment, their levels did fall with time. But the patients initially, this is probably one explanation for why relapses happen after relapses were less common in patients who were treated beyond 3 months in the UK study. So if you treat for longer, the chance of a rebound or a relapse becomes, you can think about inflammation, right? You have a lot of MOG antibodies, it's causing inflammation. You're going to have one attack, if you'll have another one in a month's time while there is a lot of antibody in circulation. And steroids possibly prevent that. But as time goes on, the levels drop and the chance of relapse becomes lower. So it is true that if you stop the steroids too quickly, then you might have a rebound relapse, particularly in the acute phase of inflammation that's happening in the CNS.
Absolutely. Dr. Meshram asks, is it possible that all patients of EDEM are actually MOG disease?
Well, they have looked at this. The Canadian study looked at that. And the short answer is no. Not all are positive. But probably there are other antibodies which are yet to be described.
Dr. Baviskar asks, chiasmal involvement, is it commoner in MOG than even aquaporin positive?
So answer is no. I think what we have seen so far is that the anterior part of the visual, the anterior visual system, in the anterior visual system, the optic nerves, the anterior is more involved in MOG as compared to the posterior bits, the chiasm and the posterior optic nerve in acute fluid disease. So overall, it's probably less common. But we have seen, as you saw in the images, there are plenty of lesions in the posterior, the chiasmal regions, in the diencephalic regions. So less common, possibly. Does not occur. I think it does occur.
Professor Satish Chandra asks, how often have you seen MOG meningitis? Can they develop neuritis later? Actually, even I have a couple of patients, Dr. Jacob, who had optic neuritis. One of them had optic neuritis and another, I don't remember now, but in their scans, they showed leptomeningeal enhancement, actually, frank, and all had pleocytosis.
That's a good point. So it's certainly being recognized, but it is not a common phenotype. And the degree of CSF inflammation may reflect the degree of meningeal inflammation, actually. So I haven't picked up anybody with pure meningeal involvement in the absence of brain lesions. But I've seen some reports of pure meningeal involvement. So it's certainly a phenotype to be reported. The mechanisms of this we have to, I think, discuss further. So it is possible. In fact, there are, if you think about the entry of the inflammatory cells into the parenchyma, meninges probably does play a role. So yes, I think this should. I mean, if you have cases, do report it.
I think there's a question on GFAP, but I suppose you've answered that they are GFAP negative. IVIG-PE also you've answered the question. In seronegative NMOSD treatment plan, so I suppose that's a completely different illness. Seronegative NMOSD who are MOG negative is a different disease.
Well, I mean, there is probably another antibody involved. Some of them are probably, formed for a state of, in my opinion, formed for a state of, MS. What is to say that? So there are two parts to it. Some of them are there's another antibody, right? So we have not discovered it. We have, if you look at a large series of MS patients, a small proportion do have lesions that are longer than 2 segments or 2.5 or 3 segments. And if they have optic neuritis and some atypical brain lesion, they would be classified as seronegative NMSD, when in reality they may actually have atypical forms of MS. So in fact, we had a study that I did for over the last nearly 10 years, 15 years actually, following up opticospinal demyelination. Many patients whom I originally thought were opticospinal diseases, could be an NMO, have over time, many of them turned out to have a typical MS. So I'm sure a small proportion of patients with apparent seronegative NMOSD may, with time, develop other lesions typical for MS. But how do you prove that? Unless you have histology, it's difficult to prove it.
Absolutely, absolutely. So at the moment, we rely on the antibodies or the clinical phenotype or the MRI, classical MRI features.
Correct.
One or all of these 3 things.
Correct. And obviously, we have to make a choice about treatment. All of this really matters when you decide treatment. You really don't want to start, if you know for sure that a particular drug is going to harm an NMO, MS drug is going to harm an NMOSD patient, then we should not, if you choose a drug, we should be careful about our choices. That is where it really matters. And I'm glad there's an increasing choice of drugs which can be safe for both.
There are a couple of 2 or 3 people asking question, what is the lower dose of steroids, maintenance steroid that you continue on?
So most of our patients, we managed to get down to about 15 milligrams of prednisolone. I mean, this is, somebody comes to the first episode of optic neuritis, MOG positive. So what happens, first month will be probably 60 milligrams, so 1 milligram per kilogram. Then we start reducing by 5 milligrams per week or every 2 weeks. And then we come down to 20 milligrams and do it even more slower by 1 milligram per 2 weeks or per week, depending on the side effects. And depending on the antibody status, etc. If they have to maintain on low dose maintenance, is between 10 and 15 milligrams.
10 to 15. You give daily or alternate day?
So we used to do alternate before, and a lot of people, it might have a safer side effect profile. But nowadays we usually we used to give alternate day before, so now we do daily. Overall, I think they do well, unless you are struggling with side effects.
Then do it. Pediatric, what would be the dose? Pediatric, would the dose be lesser?
I don't practice much pediatrics nowadays, but I think it'll be around 0.5, isn't it?
0.5. Okay. And so Dr. Meshram comes back again by asking, is edema a basket of many diseases like MS?
Short answer would be yes.
Yes. Okay.
And I'm sure there are more antibodies to be discovered.
So there are a few questions like when and which immunosuppressants, Plex, IVIG, you already answered that. Dr. Duberkar asks if diffusion positivity of optic nerve, is it typical of MOG positive patients? Diffusion positive. I
don't know the answer. I don't think we have successfully done diffusion in optic nerves because it's difficult to access. Yeah, I haven't. So I don't know the answer to that.
Dr. Nadgir asks, suppose you have had a patient with 2 or 3 relapses. Ultimately, how long to give? I suppose it's still open, isn't it? How long would you give?
How long to treat MOG-IgG, is it?
In total, yeah.
Yeah, I mean, I think there are some of our patients are onto their 4th drug. Many of them are relapsed, and we're on to treating cyclophosphamide, IVIG. They tried azathioprine, mycophenolate, rituximab. Then we have gone to cyclophosphamide, and IVIG is difficult to get in the UK, but some patients get managed. So some become quite difficult to treat. And when the disease has declared itself to be relapsing with sequelae, so we don't really can't confidently stop these patients, particularly if their neurological reserve is limited. You got a little bit of vision remaining. How can you stop? So it can be difficult in a proportion of patients. But in patients who are not relapsed, they've had one episode or two episodes. One episode is easy, but 2 episodes. When do you stop it? And the antibody may guide us. The antibody is negative. You can confidently withdraw while checking the antibodies again to see if they reappear. But if they are persistent and if the patients want to come off it, then it's a discussion. And you educate the patient. You tell them that this can relapse, but let us know quickly. These are the symptoms for it, and we will institute early treatment of steroids, plaques if need be.
There are a few neurologists asking, just after the first attack, should we continue steroids and then add immunosuppressants? So steroids become just bridging and then continue immunosuppressants. I suppose if it's a disabling and all the criteria that you showed, I answer that. What is your take on that?
So the question is, after the first episode, should you start steroids and then continue immunosuppression?
Add
right?
immunosuppressant and continue, yeah.
So, I mean, for one episode, as I said, we don't, they may not relapse again. So you don't want to use long-term immunosuppression for a long time in there. Mm-hmm. Of course, I would think about using it if they don't tolerate the steroids. Let's say a child comes, or a woman who's wanting to get pregnant comes. Sorry, not pregnancy. Let's say a child who's not brittle diabetic. Somebody's got MOG disease, got diabetes, and steroids are going to make his diabetes quite worse. In which case, after the initial period of short course of steroids and plex, and I would put them on azathioprine or mycophenolate instead of the steroids, and keep the steroid dose as low as possible. Because as you know, it will take some time for the azathioprine and mycophenolate to kick in.
Absolutely. So,
Dr. Anu, I had something to be a query. Suppose somebody has MOG, even if he has one attack and his not MOG, NMO, even if he has one attack and his NMO is positive, we say he has to be started on therapy, disease modifying for a long time. In multiple sclerosis, single attack, you might now there is a little controversy whether how aggressively you treat. What is the situation in MOG? I mean, is it amongst the milder demyelinations where you may first time just give steroid and see when it's going to relapse or how bad it is going to be?
Yeah. So it's a very good point. Why should we not treat everybody with MOG long term? But as you can see, we have had enough data to say that ADEM, the antibody disappears. It doesn't relapse again. So think of putting all these children on long-term treatment. So I think that's not right. So I think we will have to, and it's good, we can tailor treatment for the individuals. And I think the antibody will play a big role.
And even initially to begin with, MOG was the sort of phenotype where you had milder disease, fewer relapses, and not as bad as NMO is where we started looking for MOG to begin with. So
that still holds true for a good proportion of patients, but we certainly have seen a lot of patients left behind with disability, and it is those that we want to avoid. We are very lucky that we have understood the nuances of this disease quite early, and we owe it to our patients to utilize that information to tailor treatment.
So are we a little less scared of MOG as compared to NMO?
Short answer is yes. Short answer is yes. But we must know that as long as you treat the patients have access and you can treat the acute attacks well, then I think you'd be in a safer place compared to AQP4 NMOSD, where attacks can really leave behind very quickly damage. Here, MOG may recover much better if you institute treatments earlier.
Is it because it's more of demyelination in MOG and it's more necrosis in NMO?
That is partly the reason, I would guess, because demyelination, as you know, remyelination happens. The lack of complement-mediated damage may be much lesser in MOG, and complement really accelerates the inflammatory process. The destruction is much more. That may also play a role.
Okay. Shripad, I think you can take a couple of questions more and we have to let him go.
Absolutely, absolutely. I think he has answered most of them. There's one question: stroke-like presentation in the basal with lesions in the basal ganglia. Have you seen that kind of presentation?
In the basal ganglia, have I seen? No, but I told you about my patient is published. No, he had fairly acute presentations. It is thought to be vasculitis-related strokes actually. So I guess it's not impossible, but I personally have not seen basal ganglia lesions that come like strokes.
Mm-hmm.
Okay, I think we'll once again we'll thank Dr. Anu, of course. Personally, I would thank Dr. Donna Matthew for introducing him. And Donna, can you just
you,
say
sir.
the thanks, a vote of thanks to you?
Excellent talk, sir. I'd like to thank everybody for their presence. Thank you, sir. The talk was extremely good. Yeah. This
Thank you,
end the
thank you.
session. Good night.
Thank you, Anu.
Thank you very much.
Very
for listening.
comprehensive.
Thank you all. Thank you.
Thank you.
Call you again. Thank you.
Thank you.
Bye, sir.